Welcome to this deep dive. We're going to equip you with all the knowledge you need to tackle congenital hand differences on your FRCS plastic surgery exam. So let's just jump right in and get started with radial longitudinal deficiency. Okay, so let's say you're examining a newborn and they've got a shortened forearm and radial deviation of the hand. What's the first thing that comes to mind?
Well, right away, I'm thinking about the possibility of some associated syndromes. Radial longitudinal deficiency, it's often linked with things like Holt-Oram syndrome, Bacterial association, and even blood dyscrasias like TAR syndrome and Fanconi anemia.
So a thorough systemic workup is going to be really important in these cases.
Absolutely. You're going to want to do things like cardiac auscultation, echocardiography, renal ultrasound, and a CBC with differential. Those are all essential investigations. Now, while you're examining the hand itself, you really want to look closely for a specific finding. It's something examiners love to ask about: pollex abductus.
Okay, pollex abductus. Can you tell us a bit more about what exactly that is and what causes it?
Sure. So pollex abductus is when the thumb abnormally abducts when the patient tries to flex it. And this happens because of an abnormal insertion of the flexor pollicis longus into that extensor mechanism. It's a little detail, but it can really make a difference in an exam setting.
It's all about those details. And of course, we need to confirm those clinical findings with imaging.
Right. Radiographs of the affected limb, they're absolutely essential. These will help determine how severe that radial involvement is and guide our classification using the type N to type 4 system.
That's right. And just to remind everyone, type N represents thumb hypoplasia or absence, and it progresses up to type 4, which indicates a complete absence of the radius.
Okay, so let's talk about treatment now. What are some of the key things to consider when you're approaching radial longitudinal deficiency?
Well, treatment is always going to be individualized. It depends on the severity, if there are any associated syndromes present. However, the goal is always the same. You want to try to maximize hand function, and in some cases that might involve centralization of the hand over the ulna to improve that wrist alignment. Okay, so let's move on now to a specific manifestation of radial longitudinal deficiency: thumb hypoplasia. How do we go about classifying this condition?
So for this one, we use the modified Bloth classification, which ranges from type 1 to type 5 to categorize the severity. So type 1 represents minor hypoplasia, while type 5 indicates a completely absent thumb.
And how does that classification actually help us make decisions about treatment?
Well, the modified Bloth classification, it really guides our surgical approach. For instance, in type 1, where the hypoplasia is minimal, treatment might not even be necessary, or we might consider augmentation just for cosmetic reasons. But as we move towards those more severe types, more complex reconstructions are going to be required.
Can you give us an example of how that plays out in practice?
Sure. So for types 2 and 3A, we'll often perform things like web space deepening, and that's using a Z-plasty. Then we do opponentsplasty using the ring fingers FDS tendon and UCL stabilization, all to help improve thumb function.
Okay, and what if the FDS tendon isn't available? What do we do then?
Well, in those cases, we can use alternatives like the abductor digiti minimi or the EPL for our opponentsplasty.
Got it. And what about those most severe types, 3B, 4, and 5? How do we approach those?
In those cases, pollicization becomes our treatment of choice. So this involves removing that hypoplastic thumb and then reconstructing a new thumb from the index finger.
So that's obviously a pretty significant procedure. What are some of the key things we need to assess before we decide to go ahead with pollicization?
I think the most important factor is the child's spontaneous use of their index finger. If the child isn't actively using their index finger, it's unlikely that they'll be able to effectively use it as a new thumb.
So really observing the child's natural hand use is a really critical part of that preoperative assessment.
Exactly. And while we're talking about assessment, it's super important to remember the role of imaging in thumb hypoplasia. Multi-view radiographs, they're absolutely crucial for evaluating the integrity of the CMC and MP joints. And that information, it's vital for our surgical planning.
All right, let's switch gears a bit now and dive into central longitudinal deficiency, also known as cleft hand. This is a fascinating one.
Yes, cleft hand. It always makes me think of that classic quote by Dr. A. Flatt. He said, "Functional triumph, but a social disaster." It really captures that sort of dichotomy we often see in cleft hand.
That's a great quote. So what are some of the underlying causes of this condition?
Well, the etiology is multifactorial, but it generally involves disruptions in the apical ectodermal ridge during limb development.
Okay, and is there a genetic component we need to be aware of?
Yes, there is. Cleft hand can be autosomal dominant, and it's frequently associated with syndromes like split foot syndrome, EEC syndrome, and Cornelia de Lange syndrome. So again, that thorough systemic evaluation is really important.
And if you had to pick, what would you say is the hallmark clinical presentation of cleft hand?
Well, the key features you're going to see are missing or underdeveloped central digits, a variable deficiency in the first web space, and often syndactyly of the ring and small fingers. And it's amazing, so many of these patients, they actually develop really good hand function despite these anatomical differences.
It is pretty remarkable. Now, are there different types of cleft hand that we need to be familiar with?
Yes, we differentiate between typical and atypical cleft hand. So typical cleft hand tends to be bilateral. It has a familial component, and it often involves syndactyly. It may also be linked with cleft lip or palate. Now, atypical cleft hand, that's usually unilateral, spontaneous, and it rarely involves syndactyly. We often see it associated with Poland syndrome, which involves chest wall abnormalities.
Okay, and how do we go about classifying and managing cleft hand?
So we use the Manska classification, and this is based on the degree of first web space deficiency. It ranges from type 1, with a normal first web space, to type 5, where the thumb components are absent. And this classification, it really helps us figure out what the most appropriate surgical approach is going to be.
What about imaging in cleft hand? What's its role?
Radiographs are super important for defining the underlying skeletal anatomy, and this is crucial, of course, for surgical planning. They help us to visualize the extent of the bony defects and any unusual bone formations, like those transverse bones, which can guide our surgical approach.
So when do we actually consider surgery for cleft hand?
A lot of patients, they actually function remarkably well without surgery, but there are certain situations that warrant intervention. So these include progressive deformity, and this can be caused by things like deforming syndactyly or those transverse bones we talked about. Also, a significantly deficient first web space, maybe there are aesthetic concerns, an absent thumb, or functional limitations that are really impacting the patient's quality of life. In those cases, we'd consider surgery.
What about the timing of surgery? Are there specific considerations regarding age?
Well, for issues like transverse bones and syndactyly between digits of unequal length, early surgery might be necessary to prevent further complications. However, most other surgeries are typically performed, somewhere between 1 and 2 years of age. And this allows for, sufficient growth and development while minimizing the social impact of the condition.
So what are some of the common surgical procedures that are performed for cleft hand?
Well, the specific procedures really depend on the individual case and that Manske classification. But common procedures include syndactyly release first web space deepening ulnar transposition of the index finger to the middle metacarpal closure of the commissure and thumb realignment.
That's really helpful. Okay, let's shift our focus now to congenital band syndrome, also known as Streeter syndrome.
All right, congenital band syndrome. To understand this condition, we use the Patterson classification, which ranges from type I to type Fa. So type I involves a simple constriction ring, while type Phi represents a complete intrauterine disruption.
And what's the current thinking on the cause of congenital band syndrome?
Well, that older internal theory proposed by Streeter has been largely discarded. The most accepted theory now is the amniotic band theory. And this theory suggests that amniotic bands, they compress or encircle the developing limb, and that leads to constriction and subsequent deformity.
So what are some of the key things to look for when you're evaluating a child with suspected congenital band syndrome?
I think thorough prenatal history is really crucial. We need to look for things like oligohydramnios, premature contractions, and ruptures of the amniotic sac. And, sometimes three-dimensional ultrasonography can even help with prenatal diagnosis. Now, clinically, the distal segment of that affected extremity, it might appear venous and edematous, even weeping in some cases.
Okay, and how do we approach managing these cases?
Well, most cases, even those with edema, can be observed initially, as long as there's no vascular compromise distally. However, if there's significant constriction, we can perform a Hemi-Z release, and that addresses about 50% of the constriction.
And why is early correction often considered to be suboptimal?
Well, early correction often leads to minimal correction and a less favorable cosmetic outcome because the Z-flaps are so small. And it's important to differentiate congenital band syndrome from symbrachydactyly, where those distal nubbins are present.
What about the role of imaging in congenital band syndrome?
So plain radiographs, they're helpful for evaluating any underlying bony abnormalities and the depth of that soft tissue involvement. Importantly, structures proximal to that constriction band are usually normal.
So when do we ideally perform reconstruction for congenital band syndrome?
Ideally, we'll delay reconstruction until that extremity is a little bit larger, around 2 to 3 years of age. This allows us to use larger and more effective flaps.
Are there any specific techniques for reconstruction that we should be aware of?
Yes, so the Upton and Tan method is commonly used. This involves creating reverse Z-flaps of subcutaneous tissue from the Z-flaps on the skin layer and then closing in 2 layers. However, this technique isn't really feasible for fingers.
Now, congenital band syndrome can also present as acrosyndactyly, right? What are the key considerations in those cases?
Yes, that's right. So acrosyndactyly, it's characterized by distal syndactyly with proximal separation or sinus. And reconstruction in these cases, well, it really depends on the available tissues for transfer, and it often involves multiple stages. We might need to perform things like thumb web deepening, using a four-flap Z-plasty release of skin bridges, and staged reconstruction of the complete deformity.
All right, let's move on to trigger thumb now. How does this differ from the other conditions we've been discussing?
So trigger thumb, it's not a true congenital deformity. It's not present at birth. It usually develops, within the first 2 years of life.
So what causes trigger thumb?
Trigger thumb involves a thickening of the flexor pollicis longus tendon, and this is called Nada's node. This thickened portion of the tendon, it catches on the first annular pulley, and that causes that characteristic triggering phenomenon.
Okay, let's talk about the clinical presentation of trigger thumb. What should we be looking for?
The most obvious sign is going to be the thumb's interphalangeal joint being fixed in flexion. However, the rest of the thumb usually appears normal. Sometimes it can present as intermittent painful catching.
And how do we go about confirming that diagnosis?
Palpating Nada's node, that's a key diagnostic finding. You'll feel a nodule that moves with the tendon at the MP joint level. Parents will often discover this when they notice their child's thumb stuck in flexion.
And is imaging necessary for trigger thumb?
It's not usually required unless there's a suspicion of trauma.
What about treatment? Are conservative measures effective in this case?
So conservative treatments like splinting and steroid injections, which are often used in adult trigger finger, they're not very effective for congenital trigger thumb.
So what's the most effective treatment for trigger thumb then?
The most effective treatment is surgical release of the A1 pulley, and it's a relatively straightforward procedure that's performed in a controlled operating room environment.
But is immediate surgery always the answer?
The decision to go straight to surgery is somewhat controversial. Some surgeons prefer a period of observation, while others advocate for early surgical intervention. I think it's really important to involve the family in the decision-making process and discuss the risks and benefits of each approach.
And what are some of the key things to keep in mind during surgery?
Well, the aim is to preserve as much of the pulley as possible while making sure that we have adequate tendon excursion after release.
And what about post-operative care?
So typically, postoperatively, the thumb is immobilized in abduction extension for a short period. Early motion is then encouraged to prevent those tendon adhesions from forming.
Great. That brings us to our final topic for this part of the deep dive, Kirner's deformity. What's the defining feature of this condition?
Kirner's deformity is characterized by a volar radial curvature of the distal phalanx, and this usually affects the little finger.
What are some of the potential causes of this deformity?
Well, the exact cause, it's still unknown, but some possible factors include an abnormality in the physis of the distal phalanx or tethering by an abnormal flexor digitorum profundus insertion.
And how common is Kirner's deformity?
It's relatively uncommon. The incidence is about 0.15%, and it's worth noting that it's twice as common in females.
And is there a genetic component to this condition?
Yes, Kirner's deformity can be sporadic, or it can be inherited as an autosomal dominant trait with incomplete penetrance.
And are there any associated conditions that we need to be aware of?
It's important to be mindful of potential associations with syndromes such as Cornelia de Lange syndrome, Silver syndrome, Turner syndrome, and Downs syndrome.
So how does Kirner's deformity typically present?
Clinically, you'll see progressive volar radial curvature of that distal phalanx, and this typically affects the little finger. There are two main presentations, the familial form and the sporadic form.
And what are the key differences between those two forms?
So the familial form, that's usually present at birth, and it doesn't really progress significantly with growth. Now, the sporadic form, that typically develops during adolescence, and it starts with swelling along the dorsum of the distal phalanx, followed by that progressive deformity.
And does this deformity actually affect hand function?
While DIP joint motion is usually preserved, there might be minimal functional impairment.
Okay. And what about the role of imaging in Kirner's deformity?
Radiographs are usually diagnostic. They'll show that characteristic deformity, epiphyseal abnormality with lengthening of the volar lip, and metaphyseal sclerosis.
So how do we approach treating Kirner's deformity?
Well, correction is often sought for aesthetic reasons rather than functional concerns. And it's important to consider delaying surgery until the patient is old enough to participate in the decision-making process.
What are our treatment options?
Conservative management, like splinting, might be helpful during that early swelling phase. For later stages, single or multiple osteotomies might be considered to correct the deformity.
Okay, great. So that wraps up our discussion on Kirner's deformity. Are there any key takeaways you want to highlight from our deep dive so far?
I think it's crucial to remember that a thorough workup, including appropriate referrals, is essential for any suspected associated conditions. Many syndromes are not readily apparent on that initial examination.
And what about the timing of surgery? Are there any general principles we should keep in mind?
The timing of surgery is always a delicate balance. We have to consider the anesthetic risk, which is higher in infants younger than 6 months, the severity of the deformity, and the goal of, ideally completing those operative treatments by school age to minimize any potential social challenges.
Any other pearls of wisdom to share before we move on?
I think it's important to remember that the existence of, numerous surgical techniques for certain conditions suggests that a universally accepted optimal treatment, it might not exist yet. And this really highlights the importance of individualized approaches and staying up to date on the latest research.
That's really valuable advice. Okay, before we move on to part 2 of this deep dive, let's just quickly recap some of those fundamental principles of hand surgery.
Right. Because these principles, they're really the cornerstone of our approach to all hand conditions, including these congenital differences.
So what are the key things we always need to remember?
You always want to prioritize adequate blood supply, sensation, and preservation of function. Our ultimate goal is to achieve a functional prehensile hand with sensate thumb opposition, pinch, and grip ability.
So sensate thumb opposition, pinch, and grip. Those are the hallmarks of a successful outcome in hand surgery.
Absolutely. And we must always respect skeletal growth.
Right. Avoiding any interference with those growth plates is really crucial.
And just as important as the surgical aspects are social rehabilitation and support. We're treating the whole child, not just their hand.
That's such a crucial point to remember.
Exactly. With appropriate management and a holistic approach, many of these children can go on to lead, happy, successful, and independent lives. All right, so let's shift gears a little bit now and revisit radiolongitudinal deficiency, focusing on those high-yield points for your FRCS exam.
Sounds good. What are the absolute must-knows for this condition?
First off, remember that radiolongitudinal deficiency, it really represents a whole spectrum of abnormalities, ranging from mild thumb hypoplasia to complete absence of the radius. And the real key takeaway here is to always initiate a thorough systemic workup to rule out any of those associated syndromes.
So things like Holtorum, Vactorel, and those blood dyscrasias, TAR, and Fanconi anemia. We've got to think about those.
Exactly. Those are the ones that are likely to pop up on your exam. And when it comes to classification, make sure you're really comfortable with that system based on the severity of radial involvement, from type N to type 4.
Right, with type N being thumb hypoplasia or absence, and type 4 representing that complete absence of the radius.
Oh.
Okay, let's talk about some of those clinical pearls, those little nuggets of information that can really make a difference in an exam setting.
Okay. One finding you absolutely do not want to miss is pollex abductus. Now, this refers to the abnormal abduction of the thumb when the patient tries to flex it, and it's all due to that abnormal insertion of the flexor pollicis longus. It's a subtle finding, but it's a crucial detail that examiners just love to ask about.
Those examiners, they love their little details. And of course, we can't forget about imaging.
Absolutely. Radiographs, they are your go-to imaging modality for radial longitudinal deficiency. They'll help confirm that diagnosis and determine the severity of that radial involvement.
All right, let's move on to thumb hypoplasia, which, as we know, falls under that umbrella of radial longitudinal deficiency. What are the key points to remember for the FRCS?
Okay. For thumb hypoplasia, That modified Blouth classification with its types 1 to 5, that is absolutely crucial for understanding the spectrum of severity. Remember, type 1, that's the least severe, while type 5 represents a completely absent thumb.
And imaging plays a vital role here too, right?
Absolutely. Multi-view radiographs are essential for assessing those CMC and MP joints, which will really help guide your treatment decisions.
So how do we approach treatment for thumb hypoplasia? What are our goals?
The goal is always going to be thumb reconstruction. But, and this is important, we have to manage expectations. Achieving a completely normal thumb, it's often just not possible. So the focus really shifts to improving function and aesthetics to the best extent possible.
Now, I know that differentiating between type 3A with a stable CMC joint and type 3B with an unstable CMC joint can be tricky. Is there a clinical pearl that can help us distinguish between these two types?
There is. Pay close attention to the child's spontaneous use of their thumb. If they're using it routinely for pinch and grasp, that suggests a stable CMC joint, which would point you towards type 3A.
So if the child is kind of ignoring their thumb during use, it's more likely to be a type 3B.
That's a great tip. Now, let's touch upon the treatment options for each type.
Okay, so for type 1, where we just have minor hypoplasia, treatment might not even be necessary. Or we might consider things like augmentation or lengthening just for cosmetic improvement, if that's desired.
And for types 2 and 3A, what do we do there?
Those types typically require surgery. We often perform procedures like web space deepening with a Z-plasty, opponentsplasty using the ring finger's FDS, and UCL stabilization.
And if that FDS isn't available for whatever reason?
Well, then we can consider an abductor digiti minimi transfer or use the EPL for opponentsplasty.
Good to know we have those options. Now for the more severe types, 3B, 4, and 5, what's our go-to approach?
In those cases, policization is the treatment of choice. This involves removing that hypoplastic thumb and reconstructing a new one using the index finger.
So I imagine assessing that index finger mobility is absolutely crucial before we even think about going ahead with policization. Absolutely. If the child isn't actively using their index finger, it's highly unlikely it will function effectively as a thumb after policization. You've got to check that.
Okay, let's shift gears again and discuss central longitudinal deficiency, or as it's also known, cleft hand.
Yeah.
What are the key things we need to know about this condition for the FRCS?
Cleft hand. Remember that classic quote? Functional triumph, but a social disaster. It perfectly captures the essence of this condition. It can be a functional marvel, but that appearance can be challenging for patients.
It's a great quote. So what causes this condition? What leads to cleft hand?
The cause is multifactorial, but generally speaking, it involves abnormalities in the AER during limb development.
And of course, we can't forget about that genetic component and the associated syndromes.
Right. We've got to think about split hand, split foot syndrome, EEC syndrome, and Cornelia de Lange syndrome. These are all important associations to keep in mind.
What about the clinical presentation? What are we looking for when we examine these patients?
Typically, you're going to see absent or deficient central digits, a variable deficiency of the first web space, and often syndactyly of the ring and small fingers. It's pretty remarkable, actually. Many of these patients develop really remarkable functional adaptations even without surgery.
It is pretty amazing how adaptable the human hand can be. Now, are there different types of cleft hand we need to be familiar with?
Yes, there are. We differentiate between typical and atypical cleft hand. Typical cleft hand is bilateral, familial, often involves syndactyly, and may even be linked with cleft lip or palate. Atypical cleft hand, on the other hand, is usually unilateral, spontaneous, and rarely involves syndactyly. We often see it associated with Poland syndrome, which you'll remember involves chest wall abnormalities.
And how do we go about classifying and managing cleft hand? What system do we use?
We use the Mansky classification. It's based on the degree of first web space deficiency and ranges from type 1, with a normal first web space, to type 5, where those thumb elements are suppressed. This classification is really helpful in determining the most appropriate surgical approach.
Imaging is crucial in these cases, isn't it?
It is. Radiographs are essential for defining the underlying skeletal anatomy, which is crucial for surgical planning. They allow us to really visualize the extent of those bony defects and any unusual bone formations, like those transverse bones. That information is really helpful in guiding our surgical approach.
So in what situations do we actually consider surgery for cleft hand? When is it necessary?
Well, Many patients function well without surgery, but there are specific situations where intervention is warranted. These include things like progressive deformity, a deficient first web space, concerns about the aesthetic appearance, an absent thumb, or functional limitations that are impacting the patient's quality of life.
And what about the timing of surgery? Are there any specific age considerations?
Early surgery might be necessary for issues like transverse bones and syndactyly between digits of unequal length, but most other surgeries are typically performed between 1 and 2 years of age.
Can you walk us through some of the common surgical procedures for cleft hand? What are some of the things we might do?
The specific procedures are really tailored to each individual case and the severity of the deformity. But common procedures include things like syndactyly release, first web space deepening, ulnar transposition of the index finger, closure of the commissure, and thumb realignment.
Okay, that's really helpful. Let's move on now to congenital band syndrome, also known as Streeter syndrome. How do we classify this condition? What system do we use?
We use the Patterson classification, which ranges from type I to type V. Type I involves a simple constriction ring, while type 4 represents a complete intrauterine disruption.
And what's the prevailing theory on what causes congenital band syndrome?
The amniotic band theory is the most widely accepted explanation. This theory suggests that amniotic bands compress or encircle the developing limb, leading to constriction and subsequent deformity.
What are some key clinical features we should be looking for when we evaluate a child with suspected congenital band syndrome?
A detailed prenatal history is essential, focusing on things like oligohydramnios, premature contractions, and ruptures of the amniotic sac. Three-dimensional ultrasonography can sometimes aid in prenatal diagnosis. Clinically, the distal extremity might appear venous and edematous, even weeping in some cases.
How do we manage congenital band syndrome? What's our initial approach?
Most cases, even those with edema, can be observed initially as long as there's no vascular compromise distally. If there's significant constriction, a Hemi-Z release can be performed.
And why is early correction often discouraged? Why do we tend to wait?
Early correction is often suboptimal because the Z-flaps are small, leading to minimal correction and a less favorable cosmetic outcome. It's also important to differentiate congenital band syndrome from symbrachydactyly.
What about imaging? What role does it play in these cases?
Plain radiographs are helpful for evaluating any underlying bony abnormalities and the depth of that soft tissue involvement. Importantly, structures proximal to the constriction band are usually normal.
So when is the ideal time for reconstruction? When do we typically operate?
Ideally, reconstruction is delayed until the extremity is larger, around 2 to 3 years old. This allows for the use of larger, more effective flaps.
Are there any specific reconstruction techniques we should be aware of? Any go-to methods?
The Upton and Tan method, which uses reverse Z-flaps, is a common technique, but it's not feasible for fingers.
Now, congenital band syndrome can also present as acrosyndactyly. Correct. How do we approach those cases?
Acrosyndactyly is characterized by distal syndactyly with proximal separation or sinus, and reconstruction in these cases often requires multiple surgeries. We might perform things like thumb web deepening, release of skin bridges, and a delayed, staged reconstruction of the complete deformity.
Okay, let's move on to trigger thumb now. This isn't a true congenital deformity, is it?
That's right. Trigger thumb develops within the first 2 years of life, unlike the other conditions we've discussed, which are present at birth.
So what causes trigger thumb? What's the underlying mechanism?
It involves a thickening of the flexor pollicis longus tendon, known as Notta's node, which catches on the A1 pulley.
And what about congenital triggering of the non-thumb fingers? Is that the same thing?
That's a different entity altogether, potentially caused by an abnormal early flexor digitorum superficialis decussation.
Interesting. Okay, back to trigger thumb. What are the key clinical features we should be looking for?
You'll typically see the thumb's interphalangeal joint fixed in flexion, while the rest of the thumb appears normal. Sometimes it presents as intermittent painful catching.
And how do we confirm the diagnosis? What's the key finding?
Palpating Notta's node, which moves with the tendon at the MP joint level, is a key diagnostic finding.
Do we usually need imaging for trigger thumb?
Imaging isn't typically necessary unless there's a suspicion of trauma.
What about treatment? Are conservative measures effective in these cases?
Conservative treatments like splinting and steroid injections aren't very effective for congenital trigger thumb.
So what's the most effective treatment then? What do we usually do?
Surgical release of the A1 pulley is generally the most effective treatment.
Is immediate surgery always the recommended approach?
The decision to proceed directly to surgery can be a bit controversial, and it's important to discuss the risks and benefits with the family.
What are some key surgical considerations for trigger thumb?
During surgery, we aim to preserve as much of the pulley as possible after ensuring adequate tendon excursion. For congenital trigger finger affecting those non-thumb digits, releasing the abnormal tendon insertion might be necessary in addition to the A1 pulley release.
And what about postoperative care? How do we manage these patients after surgery?
Typically, we immobilize the thumb in abduction extension for a short period postoperatively, with the tip exposed. Early motion is encouraged to prevent tendon adhesions.
Okay, let's move on to our final condition for this section, Kirner's deformity. What's the hallmark of this condition? What defines it?
Kirner's deformity is characterized by a volar radial curvature of the distal phalanx, usually affecting the little finger.
And what are some of the potential causes of this deformity?
The exact cause is unknown, but potential factors include an abnormality in the physis of the distal phalanx or tethering by an abnormal flexor digitorum profundus insertion.
How common is Kirner's deformity? Is it something we see frequently?
It's relatively uncommon, with an incidence of about 0.15%, and it's worth noting that it's more common in females.
Are there any genetic considerations with this condition?
Yes, Kirner's deformity can be sporadic or inherited as an autosomal dominant trait with incomplete penetrance.
Are there any associated syndromes that we should be aware of?
It can be seen in Cornelia de Lange syndrome, Silver syndrome, Turner's syndrome, and Downs syndrome. It's also important to differentiate Kirner's deformity from physeal injuries caused by trauma, burns, or frostbite.
So let's talk about the clinical presentation. What are the key features we should be looking for?
Clinically, you'll observe progressive volar radial curvature of that distal phalanx, usually affecting the little finger. There are two main presentations, the familial form and the sporadic form.
And how do those two forms differ? What distinguishes them?
The familial form is usually present at birth and doesn't progress significantly with growth, while the sporadic form typically develops during adolescence, starting with swelling along the dorsum of the distal phalanx, followed by progressive deformity.
What about the functional implications of Kirner's deformity? Does it affect hand function?
DIP joint motion is usually preserved, so there's typically minimal functional impairment.
What role does imaging play in diagnosing Kirner's deformity?
Radiographs are usually diagnostic, showing the characteristic deformity and epiphyseal abnormality with lengthening of the volar lip and metaphyseal sclerosis.
How do we approach treatment for Kirner's deformity? What are our goals?
Correction is often sought for aesthetic reasons rather than functional concerns. We often delay surgery until the patient is old enough to participate in the decision-making process.
And what are some of the treatment options available?
Conservative management, such as splinting, might be helpful during the early swelling phase. Early treatment options include serial splinting, partial release of the abnormal flexor tendon, and dorsal hemiepiciodesis. For later stages, osteotomies might be considered to correct the deformity.
Okay, so that covers Kirner's deformity. Any final thoughts before we wrap up this part of the deep dive?
Just to reemphasize, congenital hand differences are complex and require a thorough understanding of anatomy, careful assessment, and thoughtful treatment planning.
With the right approach, we can help these patients achieve the best possible outcomes. All right, so let's move on now to some of those overarching themes and high-yield points that are relevant across a whole range of these congenital hand differences. These are the concepts that will really solidify your understanding for the FRCS exam.
Yeah, good idea. I think these overarching principles, they really help to tie together a lot of the, seemingly disparate facts.
Exactly. So first and foremost, we can't overstate the importance of a thorough workup for those associated syndromes.
Absolutely. You have to think beyond just the hand.
Right. Conditions like Holt-Oram, Vactorel, and Fanconi anemia, those should always be on our radar.
Exactly. And remember, the timing of surgery, that's a critical decision point in these cases.
It really is. It's all about finding that balance between anesthetic risk and the severity of the deformity.
Exactly. We want to minimize the impact on the child's life while still ensuring we're achieving the best possible outcomes.
And ideally, we aim to complete any necessary surgeries before the child reaches school age, just to lessen the potential for social challenges.
Yeah, that's a good point. Another really crucial thing to remember is that the absence of a universally accepted treatment for a particular condition that often indicates, ongoing research and debate in that area.
So we really need to stay up to date on the latest evidence and be prepared to tailor our approach to each individual patient.
Exactly. No two cases are exactly alike. All right, now let's take a step back and revisit those fundamental principles of hand surgery.
Those are really the foundations that guide our decision-making in all cases.
Always remember those 4 pillars: Adequate blood supply, sensation, preservation of function, and the ultimate goal of a functional prehensile hand.
Right. Sensate thumb opposition, pinch, and grip, those are the hallmarks of a successful outcome in hand surgery.
Absolutely. And we must always be respectful of skeletal growth.
Right. Avoiding any interference with those growth plates is crucial.
And just as important as those surgical aspects are social rehabilitation and support. Remember, we're treating the whole child, not just their hand.
That's such an important point.
Yeah. With the right management and a holistic approach, these children can go on to live really fulfilling and independent lives.
So to wrap up our deep dive on congenital hand differences, let's just do a quick review of some of those high-yield points for your FRCS exam.
Yeah, a quick recap to solidify that knowledge.
Okay, so starting with radial longitudinal deficiency. Thorough workup for those associated syndromes. Absolutely essential. Make sure you understand that classification system and the significance of pollex abductus.
For thumb hypoplasia, that modified Bloth classification is your guide. Observing the child's spontaneous thumb use can help differentiate type 3A from type 3B. And don't forget to assess that index finger mobility before considering pollicization.
Moving on to central longitudinal deficiency, or cleft hand. Remember that quote, functional triumph but social disaster. It's a great way to remember the challenges this condition presents. Distinguish between the typical and atypical forms, and use that Mansky classification to guide management.
With congenital band syndrome, a detailed prenatal history is key. Remember that amniotic band theory and the importance of differentiating it from symprecadactyly. And delayed reconstruction, that's often the preferred approach.
For trigger thumb, remember it's not a true congenital deformity. Surgical release of the A1 pulley is generally the most effective treatment.
And for Kirner's deformity, correction is often sought for aesthetic reasons. It's a good idea to consider delaying surgery until the patient can participate in that decision-making process. And splinting, that can be a helpful tool in those early stages.
And finally, remember those basic tenets of hand surgery. Prioritize blood supply, sensation, and function. Respect skeletal growth. And don't forget the crucial role of social support.
Excellent summary. With careful assessment, a solid understanding of hand anatomy, and thoughtful treatment planning, we can really make a difference in the lives of children with these congenital hand differences.
Well, that concludes our deep dive for today. We hope this information has been valuable as you prepare for your FRCS exam. Best of luck with your studies, and remember, the journey of learning never ends.